Are you ready to advance your career in one of the most dynamic and impactful fields in healthcare? Welcome to the Cardiac Critical Care Fellowship, an entirely online program designed to fit your busy schedule, offering 3 comprehensive modules, each worth 30 credits. Learn from world-class clinicians and gain access to evidence-based content, cutting-edge research, and real-world case discussions in cardiac critical care. This program is tailored for self-driven learners who want to take control of their education and unlock their potential. Whether you're managing critically ill cardiac patients or looking to master ECMO, mechanical circulatory support, or perioperative care, this fellowship will empower you to excel. With flexible, interactive, case-based learning, you'll gain the skills needed to advance in this high-stakes field, all while earning certification to boost your career. Join us today and start your journey towards becoming a leader in cardiac critical care. Are you ready to make a difference?
Good day, everyone. Welcome to our webinar for Cardiac Critical Care Program. My name is Ashwag Mahdali, and I'm delighted to be your host today. We are honored today to be joined by 2 international expert speakers, Prof. Alan Combs and Prof. Eddie Van, who will share their expertise and insight on evolving role of ECMO in cardiac surgical patient. Special thanks to Dr. Aus, our moderator today, for his continuous support for our program. Thank you for the audience for joining us today. We hope you will find our session informative. This webinar is being recorded and will be available in our YouTube channel. The session is approximately 60 minutes with 10-minute question. Feel free to submit your question using the Q&A box. Without further delay, the mic is yours, Dr. Aus. You may share your slide, Prof. Allen. Thank you again.
Thank you very much, Ashwag, for the kind introduction, and thank you very much for our expert speakers for joining us today to talk about ECMO in general post-cardiac surgery. We're honored to have Prof. Alan and Prof. Eddie Van with us today to talk about, I think, VA in the first lecture and VV in the second lecture, post-cardiac surgery. So Prof. Alan Combs is a professor at Sorbonne University and the head of ICU in La Petite Salpêtrière Hospital in Paris. He will talk about VA ECMO after cardiac surgery to start. The mic is yours, Alan.
So thank you again for this kind invitation to your webinar. I will discuss ECMO as a rescue strategy in cardiac surgery patients. So those are my disclosures. So what will be the agenda? First, I will discuss with you what is post-cardiotomy ECMO, the epidemiology and trends, the patients we might have, how to cannulate, discuss the management, complications, outcome, and what might be future perspective in that field. So first of all, what is post-cardiotomy ECMO? By definition is the device used in patients who have refractory cardiogenic shock despite optimized medical management, including maximal pharmacological therapy. It's meant to support the organ recovery, and while the myocardium is damaged or temporarily damaged, or until a decision is made, and ECMO in that frame might be used as a decision device. And actually, when looking at the epidemiology, it's still right now the most frequent ECMO indication in the US. So I will not extend a long time on what is VA. VA is draining blood from a big vein and re-injecting the blood most frequently in the distal part of the aorta to provide cardiac and respiratory support to those patients who have severe cardiogenic shock. So what is the epidemiology of cardiogenic shock, severe cardiogenic shock in that setting? It's obviously and hopefully low in incidence, less than 4% in the open heart surgery patients. But there's been, when looking at the way we manage these patients, a huge increase in the use of ECMO in recent years worldwide, including the US, where we have maybe a little bit more data. So what is post-cardiectomy cardiogenic shock? It's refractory cardiogenic shock after cardiac surgery. Whether it is just at the end of the surgery with inability to wean the patients from CBP. It might be a little bit delayed also with the patient developing shock in the hours following surgery, all of which will result in, as usual in severe cardiogenic shock, inadequate tissue and organ perfusion, leading to multiple organ failure with, at the end, the deaths of the patients of those multiple organ failure. The mortality remains very high, especially in the setting of post-cardiotomy cardiogenic shock, with a mortality which is at least 40%, might be even higher, especially if MCS support is not possible. So, well, is it a different population of patients when comparing the characteristics to those who got a VA ECMO in other types of setting, for example, after a medical disease, acute MI, and stage heart failure? For sure it is, especially regarding age. Most frequently, those patients are older than in other series of VA ECMO patients. Age per se should not be an absolute contraindication to this strategy. Otherwise, we know that, well, the impact of age will be obviously important here. Also, when looking at the baseline profile of the patients, higher rates of renal insufficiency and prior MI, left main coronary artery disease. Of course, those patients who already have LV dysfunction pre-op might have a more frequent rate of post-cardiogenic cardiotomy shock. Also, prior open heart surgery is probably linked to the previous factor, might also be associated here with this profile. Surgical trigger, when looking at series of patients, CABG seems to be the most frequent. Also valve surgery, especially when combined. Procedures might also be aortic surgery, dissection. There is a very specific group of patients, those who have heart transplant, primary graft failure, whether it is linked to severe right ventricle failure post-heart transplant, when the right heart from the graft needs to adjust with the PA pressure, which might be still elevated in some patients, and ECMO clearly here might help, or because it's a primary graft failure because of, for example, a suboptimal conservation of the graft and before surgery. This might also be a post-VAD, post-left VAD implantation, which is the most feared complication of VAD surgery when the RV failure occurs post-heart surgery. And this is something which is actually quite challenging to manage, and VA ECMO might be a temporary solution in that case. So those are the indications here. Failure to wean from CBP is probably still the most common when the patient cannot be separated from a cardiopulmonary bypass. at the end of surgery. Refractory cardiogenic shock may be also delayed during the ICU stay within the following hours. Might be also ECPR because of cardiac arrest in the ICU post-op. Intractable arrhythmias might also be an indication in some patients who have this specific disease, and I already discussed the primary graft failure problem, which may be up to 10-15% depending on the strategy for graft allocation. I will touch base on the specific respiratory failure indication at the end of that talk because it's very specific here and not the most common setting of ECMO in the post-cardiotomy setting. If we are discussing the timing of cannulation, as always, if there is a delay in the decision, the patients will develop more severe organ failure, and the outcome will be impacted here. The sooner the better, as long as the patient qualifies for refractory cardiogenic shock. Usually it's either very simple because the patient cannot be weaned from the bypass. In the ICU, there's a need to close monitoring here for the escalating doses of vasopressors and inotropes in the patients. Clearly, once again, ECMO survival might be delayed, might be impaired if the decision is too late. It does not mean that prophylactic ECMO should be used. We may do it in selected cases, especially, for example, patients who are bridged to heart transplant on ECMO. We usually do not remove the ECMO machine at the end of surgery. We get the patients back in the ICU and evaluate, especially the right ventricle, in the following hours and 1 or 2 days. And if everything is okay, we will remove the ECMO device, let's say, after 24 to 48 hours. Might be the same for patients who reach the operating room on ECMO. It might be wise to let the ECMO run once again, at least for some hours, 1 or 2 days, to check for global heart function before removing the device for patients who reach the operating room under ECMO for severe cardiac failure. Cannulation strategy, peripheral versus central. This is something we have clearly modified in the last 10-15 years. Central cannulation was the rule before, let's say 2015. And then we moved to a fully percutaneous fem-fem VA strategy. And when looking at the recent literature, it's also the strategy which is used by most centers recently, because obviously it's going to reduce the risks of complications such as infection, mediastinitis. It's much easier when the patient is under CPR. With the systematic use of the distilled perfusion catheter, we have much less ischemic complications than before. Obviously, apart from infection, it may also reduce the rates of bleeding. Central cannulation, well, clearly not that frequent because of the risks I've just discussed right now. This might be the case in selected cases in our experience here, but it's not a classical central. The central cannulation we use is using 2 ECMO devices as a BiVAD. For example, in patients who have been on VA, peripheral VA for some time, up to 2-3 weeks, and then get complications. The patient might be a candidate for something else, which might be a heart transplant or a VAD, but too sick to get it immediately. So we might, in that situation, move to sternotomy, double central ECMO with a ECMO on the right side from the right atrium to the pulmonary artery, and the left side from the apex of the left ventricle to the aortic root, which may be in place for a couple weeks, time for the patients to stabilize and hopefully sufficiently recover organ function before getting back on the transplant list, for example. Another very burning question is the need for, or the not need for, LV unloading or venting. Via ECMO, as you know, increases the LV afterload, although it's not systematic. This is something we recently have shown and published in a JACC paper. There's two main dogmas. When you put a patient on ECMO, is going to have to lead to an increase in the LV and diastolic pressure and the wedge pressure, and actually it's not true. In the series we published, 2/3 of the patients did not have an increase in the wedge, and there was a second dogma: the higher the ECMO flow, the higher the PAOP and the wedge pressure, and obviously it was also not true. On average, there was even a trend to a decrease in the wedge pressure in that situation. So we do not have yet a full picture of the population of patients who might actually need a vent. But for those we need, is probably an impact in the outcome. This is a reason why there's many papers in VA ECMO generally, or in meta-analysis of patients like this one here by Meani, which showed that an unloading device was used in around 40% of the patients, and unloading was associated with a lower mortality. But as always, those results might be confounded by many biases, indication biases. So there may be a need to go for an RCT in this specific population of patients. We are running in France right now the Euliodia trial in VA, but not specifically post-op. Post-op patients are included, but it's the whole spectrum of cardiogenic shock on VA, and we're randomizing patients VA plus the balloon pump immediately versus monitoring and escalation to some form of LV venting with the balloon pump or the impella if needed. So we may have some more information in the coming years. There is also a PARA study which is ongoing in Germany with the impella with roughly the same protocol. So, well, in our opinion, the balloon pump should be used first line because it's less invasive. The diameter of the introducer is smaller. Let's say 8-9 French as opposed to 14 for the impella. And although the unloading and the decrease in the LV and diastolic pressure is less, is around 5 to 10 milliliters of mercury, this may be enough for most situations if the patient needs an unloading device for sure. This is a reason why, once again, we need to have more data on that. But when looking at the literature, clearly it's the IBP which is most frequently used in that situation. Also, it remains controversial and it probably will be for the coming years. Another major point which needs to be discussed is the anticoagulation strategy in those patients who have undergone heart surgery very recently, and balancing the risks of thrombosis and hemorrhage is quite complicated here. In the 6 to 12 hours following surgery, those patients might bleed and might have severe bleeding, and it's even more complicated in the patient who put on VA because if you look at the recommendation, patients on VA should receive full anticoagulation because of the high risks of thrombosis. So the strategy here is to go for anticoagulation if the patient does not bleed through the drains, with the use of low to moderate doses of unfractionated heparin within the first 12 to 24 hours, and if everything is okay, the dose might be increased. Other types of dose, bilaviridine, other types of anticoagulants may be used by some centers, although the literature for now is not large and not highly convincing. And it may be that heparin might be the least complicated to manage, especially if the patient gets severe hemorrhage. It's easy to manage to cut the infusion and even to have an anti strategy to cut the activity of the drug. It's quite complicated because those patients obviously have a higher tendency to bleed because of the surgery, because of the surgery-associated coagulopathy, and on top of that, you add the coagulopathy and the platelet also modifications which are linked to the use of ECMO. And it's even more complicated if the patient has received a mechanical heart valve, especially a mitral one, and which needs full anticoagulation. Then you need to really adjust very precisely and balance, once again, the risk of thrombosis and hemorrhage. The duration of support varies among series. It's not that long. Usually it tends to be shorter than in other series of VA patients, with median time of ECMO being between 2 and 5 to 6 days. In patients who do not recover very rapidly, especially those who are elderly patients, when complications occur, the situation might become quite complicated with some ethical issues. And this is a major point here, because once you put a patient on VA, you need to have the family informed of the strategy you're targeting with VA, and especially if the patient does not become a candidate for a heart transplant or a VAD surgery. You may explain to the family that the bridge here is to recovery, and if there's no recovery, let's say within 7 to 10 days, there might be a discussion with the family or the patient himself, if the patient is awake, towards winning from VA because of unethical decisions. It's quite complicated here to manage. Complications, obviously, because of the epidemiologic characteristics of the patient, the setting of post-heart surgery, the complications tend to be more frequent than in other types of VA patients. All types of complications here, but with bleeding being the most frequent, together with renal failure, which is clearly here a combination of the pre-op characteristics, the impact of surgery, and if the patient has developed post-op cardiogenic shock, the shock also might become quite a severe issue. And well, looking at all the complications, infections, vascular complications are also appears from time to time, and ischemic complications tend to be quite low, especially if there is the use of distal perfusion cannula or catheter to prevent the complication, the ischemic complication. Bleeding, I did already touch on that major point, which is related to many factors, the severity of the patient, the surgery itself, and ECMO, of course, Not to mention the Willebrand, acquired von Willebrand syndrome in ECMO patients, which is a constant here. And once again, well, infraction heparin might remain, at least for us, the first-line strategy in these patients. Neurological complications is also a Fiat complication in these VA patients here. In general, it occurs up to in up to 15% of the patients on VA. And here we'll obviously are talking of patients, a population which might have even a higher risk than in other ECMO indications, once again, because of the disease, because of the age of the patient, and because of the severity of shock post-op, might be stroke. Of course, if it's intracoronary hemorrhage, it might be even more severe. And there should be a very low threshold here for neuroimaging. Actually, if it is performed, there might be more injuries detected by the CT than if the CT was not performed. Limb ischemia and vascular access is a major also concern. Once again, the cannulation should be percutaneous, Doppler ultrasound guided, fem-fem, with the insertion of this perfusion line, which should be positioned into the superficial femoral artery. And you may take help of a very simple maneuver here is the injection of agitated saline through the perfusion line and taking your Doppler probe to check for the appearance of the micro bubbles into the popliteal artery. It takes 30 seconds and it makes sure that the line is correctly positioned. Continuous near-infrared spectroscopy, NIRS monitoring is used in many centers, including ours here in Paris, to detect early the hypoxia on the limb. Renal failure, quite frequent, and it's an independent factor for mortality. It's the case in most ICU patients, and here there's many reasons for the patients to develop renal failure, and if needed, CVVHH, HDH might be used to stabilize and deal with the severe water retention plus hyperkalemia if this is the case in these patients. Winning, well, it should be winning with long-term a successful outcome, at least patients surviving at least up to day 30. It might be very different from series to series, and when looking at mortality, it may be even higher. Will clearly depend here on the characteristics of patient's mortality. Will be higher if ECMO was used in patients over the age of 70. It may be up to 70 to 75% if there is no major restriction regarding the age of the patients. And we are back to the predictors of the outcome. Severity of cardiogenic shock, ECPR, advanced age, diabetes, severe pre-op LV dysfunctions, obesity are clearly factors associated with higher mortality, together with the severity of the patient's post-ECMO initiation. And of course, if the patient's developing neurological complications, you may even reach mortalities up to 80 to 90%. And well, this is in that series from Kleinlein in BMC anesthesiology reporting here the factors including diabetes, hypertension, and male gender, which were associated with mortality. So ECMO is usually meant as a bridge to recovery in these patients, especially if their age is beyond the upper limit for transplant and surgery. And if it's the case, the survival might be okay if no major complication occurs. It may be used as a bridge to a heart transplant. There is no heart recovery and the patient qualified. Also, the prognosis in these patients might be also impacted by the severity of postoperative shock. Elderly, I've already mentioned that, should not be definitive complications, but should be clearly discussed case by case here. Also with a clear discussion with the family once the ECMO has been set up. Just one word about VV for respiratory insufficiency, which is much less frequent. The patient might have both cardiac and respiratory failure, and VA ECMO might be the solution in these patients, but isolated respiratory failure is not that frequent. There's some reports of VV ECMO in that setting, and probably we are back to Aeolia criteria, for example, to decide the insertion of VA ECMO in these patients. And there's few series suggesting that the prognosis might be much better in those patients. Long-term outcome for those who survive is not that bad, especially if the age is less than 70. This is the reason why now it's probably mandatory for every heart surgery center to have access to VA ECMO to set up the device at the end of surgery if the patient has major issues with the weaning of the bypass or develops cardiogenic shock in the hours following surgery. Last but not least, there is a need to benchmark this activity because if the results are quite poor, it's still using a lot of resources. There may be some centers also with financial incentive to go for ECMO. There's been some autopsy series in patients dying post-op, which led to unrecognized illnesses, which might have limited the initiation of ECMO. So it's a complicated story here, but if you have a good and large active program, clearly VA ECMO should be part of the program for post-op cardiogenic shock, but benchmarking is very important here, together with education as always. There might be also technology improvement in the future for all our VA patients, and also research, just benchmarking as I mentioned before, but also discussing, for example, the indications of venting, ECMELA versus the balloon pump, and long-term quality of outcome as quality of life as always for ICU patients. And this is here a key summary. So it's rare, probably less than 5% of all heart surgeries, but it may be elevated in centers doing a lot of heart transplants, valve surgery, and complicated surgery, in which the incidence might be up to, maybe 7 to 8%. If initiated early, the prognosis might not be impacted that much. And for those who survive, it's always the case post-op and completely recovered. The outcome may be quite good in these patients. And with that, I would like to thank you very much. This is today the last day of our ECOS TCS meeting in Paris. There will be one other next June, around the same dates next June in 2027. And we also have our ECMO courses, which qualify for ADA, so step 1 and 2. And it would be a pleasure for us to have you in Paris sometime in the future. And with that, I would like to thank you very much for listening. Thank you.
Thank you very much, Prof. Alan Combe. Very comprehensive and good lecture. We have 2 good questions here. We're running a little bit over time, so I'll throw them together at you, and then you can answer them both together. So question number 1 is about the cannulation strategy. So when do you decide to do peripheral rather than central ECMO post-cardiotomy? If you have the chest open, I would imagine that central is much easier and you can flow higher and all of that. And the question actually was like, if somebody developed cardiac shock in day 3, 2, 3 after cardiac surgery, would you take him back to OR for cannulation, central cannulation, or would you just cannulate peripherally? Second question is about running CRRT simultaneously with ECMO. What's your practice? Do you do it in the same circuit? Do you do it in a separate circuit? And how much do you flow? Thank you.
Okay, so to answer that question rapidly, first, the sternum should be closed. No discussion. Because the rate of complication will be much less with peripheral VA. No question about that. And only very few patients and only about selected indications receive central VA, and for us, most frequently, once again, the double central as a BiVAD. But it's for less than, I would say, 2 to 3% of our cases post-op. Second, CRRT, it will depend on the ECMO kit we're dealing with. There's some ECMO kits for which it's very simple to connect because there's lines on the circuit. For some other machines, it's not easy to do it. So we still use venous dialysis catheter in these patients to dialyze it. But every time it's possible, once again, it's one line which is paired with less risks of infection and etc. And VA is a perfect situation here because the problem of the CRT machines is the pressures in the return line. And on VA, obviously, the pressures are lower because the blood flow is lower than in VV. So it's a perfect situation if possible, but once again, it's not possible for every manufacturer.
Thank you very much, Professor Alan Combe. Very good answers and good lecture. Very informative. Thank you so much again. So we'll be switching gears now to VV ECMO, post-cardiotomy, post-cardiac surgery. Our speaker is Dr. Eddie Fan. Eddie is a professor of ICU in University of Toronto. He's also the medical director of the ECMO program at the Toronto General Hospital. Eddie, the microphone is yours. Your mic is still off.
Sorry, having troubles managing the multiple windows. Okay, so first I'll unmute. Thank you for the invitation. And then I'm going to share my slides. Here we go. Can we see the right ones, I think? So thanks for the kind invitation. Always difficult to follow Alain in a talk like this. And Alain's already given, I would say, a nice overview of everything that I'm going to say about VV ECMO in cardiac surgical patients. So if VA ECMO, as Alain concluded, was relatively rare, I would say VV ECMO use in cardiac surgical patients is probably even rarer, but we can go over some of the ideas and these patients. Here are my disclosures. I won't be speaking about any specific devices. And really, we're talking about, for VV ECMO and cardiac or cardiothoracic surgery, maybe 4 cases. Again, all of them, except for lung transplantation, probably on the rare side. So the first would be what Alain already described, which would be post-cardiotomy ARDS, so managing severe ARDS that complicates cardiac surgical patients. Lung transplantation, I think maybe not the primary focus of today's session, but to give some brief insights into how VV ECMO can be used as a bridge to lung transplant or postoperatively in patients who have primary graft dysfunction. There's theoretically some use in minimally invasive cardiac surgery where you can use it as a temporary measure to help provide oxygenation during single lung ventilation. And then again, probably a rare situation, but patients who have pre-existing lung disease, say chronic obstructive lung disease, COPD, or these sorts of things, and the idea of supporting these patients through complex open heart surgical procedures could be considered. So again, just to basically begin with a brief overview of the difference here. Now we're talking about VV ECMO, which is distinct from Alain's talk on VA ECMO. So we're talking about a circuit that's connected in series with the native cardiopulmonary circulation as providing lung support only and really not any cardiac support. And overwhelmingly, I guess in 2026, for the vast majority of patients who are on VV ECMO, typically through a 2 cannula system like in panel A, and maybe less frequently and panels B and C. C with the dual lumen bicable cannulas perhaps being more used in my center in patients who are bridging to lung transplantation. We'll talk briefly about that in subsequent slides. Just to remind you that the evidence base for VV ECMO really comes from its use in ARDS, and a reminder that this technology is actually not very new, despite the fact that an explosion of use over the last few decades and certainly since the pandemic. But this is an old technology. This is the very first trial of VV ECMO in severe respiratory failure. Again, not necessarily cardiac surgical patients, led by Warren Zapel. And you can see amongst the authors many of the pioneers of ECMO support back in the 60s and 70s. This trial randomized 90 patients to VV ECMO or best mechanical ventilation alone. And what you see here is survival. Survival was about 10% in both groups. So this told you two things in 1979. If you're an adult with severe respiratory failure, you're in big trouble, and ECMO wasn't going to help you. Okay, and this sort of study unfortunately dulled enthusiasm for VV ECMO in general for the management of severe respiratory failure for many years until the last pandemic. So in 2009, of course, we had H1N1 pandemic, and this one very similar to COVID, where relatively young, healthy patients, some of them pregnant, showed up to ICUs around the world with very severe refractory hypoxemia and were dying of that cause. And in fact, in this very high-profile case series, from Australia, New Zealand, 68 such patients received ECMO. And interestingly, again, this is an observational study, so there's biases and confounding, but interestingly, the survival here was 71%. And actually, by the time they followed patients up following the publication, it was closer to 75%. So interesting that in 1979, it was 10% survival. And now in 2009, we had 70% survival. So clearly a lot of things had changed, including improvements in technology, general ICU care had been better, aggressive management of sepsis and respiratory failure, and certainly, again, a selection in this case series of patients who are young, otherwise healthy patients, but something there to trigger people's ideas that VV ECMO could be used for severe respiratory failure. And of course, that culminated in the CSER study led by Giles Peake in the UK, where they randomized 180 patients with severe respiratory failure to either getting best conventional mechanical ventilation at their home site versus being transferred to Leicester, the Glenfield Hospital, which was the adult center for ECMO at the time, for consideration of ECMO. And for the primary outcome of 6 months survival without disability, indeed, there was a significant benefit to VV ECMO in these patients. But again, in the interest of time, we won't get to all the nuances, but what you can see here is that there's this little asterisk beside the ECMO group. And of course, the challenge here was that of the 90 patients that were transferred to Leicester, randomized to be considered for ECMO and were transferred to Leicester, not all of those patients went on to ECMO. About 25% of those patients, they changed the sedation. They tried high-frequency oscillation. They prone. They used inhaled vasodilators. They made some changes, and up to 25% of them improved and didn't require ECMO. So this was less a trial of ECMO versus no ECMO than it was a trial of transferring patients who were very sick to an expert center for the management of respiratory failure, and you could get ECMO as a part of that. So skeptics continued to wonder whether it was the VV ECMO that was really saving lives. And so that, of course, then spurred Alain, who led us in this landmark trial, the EOLIA trial, on the left that you could see, to sort of pick up where the CSER trial left off, was to use expert centers and very protocolized management in both the control group and the ECMO group to really understand, is it the VV ECMO that's helping patients? This was an adaptive trial that was designed to randomize 331 patients. It was stopped early after 249 patients were enrolled at a planned interim analysis. And it was stopped due to futility, in that, not futility of the intervention, but that if we were to continue to 331 patients, we were unlikely to show a statistically significant result through simulation. The interesting thing here is that you could see from the Kaplan-Meier curve, the primary outcome of 60-day mortality, there was an 11% risk difference in favor of ECMO. And almost all the secondary outcomes were also in favor of ECMO. So again, no time today to talk about the almighty p-value, dichotomizing trial results as true versus false or good versus bad. But needless to say, the signal in this trial was in favor of ECMO. And when your primary outcome doesn't turn out the way you like, you look to secondary analyses. And on the right, what you could see is that following the EOLIA trial, there were a number of secondary analyses that all supported the use of VV ECMO in severe respiratory failure patients, including a Bayesian reanalysis led by my colleague here, Ewan Gallagher, that showed across a range of prior beliefs, including very skeptical priors, there was over 88% chance of benefit of ECMO in these patients, and that neared 100% if you had an optimistic view. We had study level meta-analyses, individual patient data meta-analyses, and now one of maybe 5 network meta-analyses that all showed a significant effect for ECMO in this patient group. That's now been codified into clinical practice guidelines, including from ESICM, suggesting the use of VV ECMO for patients with severe ARDS following the EOLA criteria and in expert centers, and very similar recommendations and an update to the ATS guidelines that recommended the use of VV ECMO for these patients. So again, in thinking about the cardiac surgical patients, this is probably, again, overall, the reasons will be rare, but this is probably, if you're thinking about VV ECMO use in these patients, where it might fit is that in patients who have post-cardiotomy, ARDS, or severe respiratory failure, these might be the patients who qualify for VV ECMO. And I think the thing to recognize here is that postoperative pulmonary complications are common in surgery in general. So it's one of the most common complications following any kind of surgery, whether that's cardiac or non-cardiac. And these complications are, of course, associated with patient-important outcomes like higher morbidity, higher mortality, increased length of stay, and costs. Cardiac surgical patients are probably at particularly increased postoperative pulmonary complications because bypass leads to a systemic inflammatory response. There's oxidative stress on the lung. You get pulmonary ischemia reperfusion that can lead to lung injury. During cardiopulmonary bypass, depending on the operation, there could be disruptions in mechanical ventilation that lead to atelectasis, which may be difficult to deal with. And of course, there's some factors related to the specific type of surgery, the anesthesia that's used, how many blood transfusions are provided, etc. But there are high risks of complications, and they're exceedingly common. So this is just one more recent publication from the Venice group showing that you could see here that these complications, there are a range of complications, including things like atelectasis and pleural effusions, but a good proportion of patients still having some degree of respiratory failure, and then others like infection, pneumothorax, bronchospasm, etc. So very importantly, a common complication, but indeed frank respiratory failure and certainly severe respiratory failure that's refractory to conventional measures requiring ECMO is probably a pretty rare phenomenon. Alain sort of talked about risk factors for the need for post-cardiotomy ECMO. I think these risk factors are pretty similar when you look at 2 larger case series of nearly 3,000 and 6,000 patients, which show, again, older age, worsening LV dysfunction, pre-existing respiratory disease, the type of operation that's provided, pre-existing lung disease. These are all risk factors for having pulmonary complications postoperatively. And again, despite the fact that complications are common, so up to a third of patients might have some kind of pulmonary complication postoperatively, severe complications are probably on the rare side of things. And certainly severe complications, even requiring ECMO, are exceedingly rare. And that's why you get basically this kind of data where even in a case series, and I think Alain spoke to this study from Korea, showing that you basically, even looking at 13 patients with amongst their very busy cardiac surgical population that received VV ECMO postoperatively for some kind of pulmonary complication, including congestion, pneumonia, and that sort of thing. And amongst these patients, pretty good outcomes though. Nearly 70% were weaned, and 1-year survival was 60%, even amongst this very severe group. And I think pay particularly close attention to the fact that the reason these patients died was not necessarily related to the respiratory failure in and of itself, but to be vigilant about secondary causes, especially sepsis in this case series, was sort of the main reason that these patients died. So certainly the operation was already a major risk factor. Their pre-existing comorbidities is a risk factor. And of course, severe respiratory failure and the need for ECMO probably increased their chances of developing nosocomial infections and death as a result of sepsis. Is something to be vigilant about. And again, we have some larger series. This one is from Europe, led by Roberto LaRusso's group in the PELS-1 study, looking at patients who were receiving perioperative ECMO around the time of cardiac surgery. This one focusing specifically on VV ECMO. And again, I really want just to highlight that, again, exceedingly rare. So pulmonary complications common, could be as innocuous as things like atelectasis and an effusion, but frank respiratory failure requiring ECMO, 1% in this study. So pretty rare sort of situation. And again, when you look at the case series to date, so PELS is the one that we're just talking about here, very small number of patients, the Song study from Korea we just mentioned. But again, you could see it's very interesting, depending likely on more patient factors and operative factors, you get a pretty wide distribution of outcomes here in survival to discharge, as high as 50 or 60% in some of these studies from Song and Nakamura, but as low as 21% in the PELS 1 study here. And again, interesting to see that many of the complications are either related to sepsis and nosocomial infection or bleeding and other risks associated with the ECMO procedure, which again, likely some of these patients are at higher risk for, leading to their need for VV ECMO in the post-cardiac surgical setting. I think something to not forget is that in patients who might, again, it might be rare to have isolated RV dysfunction or have a RV dysfunction that either is complicating ARDS or related to their surgical option. There is the venopulmonary route of configuration of cannulation that could lead to some RV support, where the cannula the tip is inserted into the pulmonary artery and drainage is from the right atrium. There's some indications that this configuration can provide stable oxygenation as well as some RV protection. Again, the quality of the data at the present time is a little bit less rigorous than others, mostly case series, many of them single center, looking at this kind of venopulmonary configuration. But the data, at least at present, suggests lower rates of mortality, lower rates of AKI and need for renal replacement therapy as compared to others. And again, the thinking is that at least in patients who have RV dysfunction complicating or RV injury complicating their course, that this configuration might confer better organ support by providing some RV decompression and RV support. So something to consider in those kinds of patients. Again, briefly about lung transplantation, because this is something near and dear to our hearts in Toronto, having been the first center in the world to perform successful single and then double lung transplantation. And in our center, that's how our ECMO program had begun. It had begun back in the 70s when they were experimenting with lung transplantation. We described with some of these pioneers the use of ECMO to support those patients early in lung transplantation. And really, it's evolved over time to the point where now, again, donor lungs are becoming more and more available, but certainly back when they were scarcer and people were dying on the waiting list, bridging patients to lung transplant, and here's an example for patients with pulmonary hypertension, actually decreased waitlist mortality from 22% to 0 in our program back in the 2000s. And so again, this is a powerful tool in patients who decompensate while waiting for lung transplantation to bridge them. And of course, the next phase of that was to show that not only could you support the patient successfully to lung transplantation, but you could probably support the patient in a way that they could be awake, interactive, and undergo physical therapy to have even better long-term outcomes following lung transplantation. This is work from the Hanover group showing sort of maybe the first proof of concept that the awake ECMO bridging could be very useful in these patients. And of course, that's something that now we strive for in our patients who are bridging to or from lung transplantation. This is a lady with lymphangioliomyosarcoma who was waiting for lung transplantation, came in with hypercapnic respiratory failure. And day one after getting onto ECMO, she could be exercising with 2 of our senior physical therapists while waiting for her lung transplant. Outcomes seem to be very similar, at least again in our program, amongst patients who are bridged to lung transplant with ECMO as compared to without. And again, when you look at longer experiences, not only in Toronto, but also in Vienna, which is a busy program in Europe, you get very similar results, certainly especially as the groups have moved from using VA ECMO to increasingly VV and sometimes even CO2 removal devices to bridge these patients to, it seems that the mortality or survival has improved, and actually the rates of PGD following transplantation have also improved. So that's now become the standard for patients, at least in our program, who decompensate and are waiting for lung transplant to be bridged awake, if possible, on VV ECMO. There is probably some, again, theoretical use of VV ECMO intraoperatively for patients undergoing minimally invasive cardiac surgery. And again, this is the idea that sometimes it might be difficult, especially if you're operating on patients who have pre-existing lung disease, to maintain oxygenation with single lung ventilation after you've weaned from cardiopulmonary bypass. And sort of putting these patients or converting them to VV ECMO may obviate the need for overinflation of the left lung or sort of intermittent double lung ventilation to support the patient after they've come off bypass. This is a small case series, again, from a Japanese centers sort of discussing their experience with this sort of temporary use of VV ECMO during minimally invasive cardiac surgery. Again, really quite well tolerated, very low 30-day mortality, very small number of post-operative complications. So again, at least from a theoretical point of view, something that could be entertained in this group of patients. And then finally, to talk about something that's probably even rarer than post-cardiac surgery ARDS is the idea that, in patients waiting for certain cardiac surgical procedures with underlying pulmonary disease that might exclude them or preclude them from undergoing operations, could you bridge them to that with VV ECMO? And again, there's very limited data to support the routine application of this process. But again, there are published studies suggesting there are centers out there that are doing that. This is one older study from the 90s showing 39 patients with severe lung disease, most of them with obstructive lung disease. And these patients tend to have worse outcomes if you take them to surgery, which again is maybe not surprising. They have longer ICU length of stay. This is more prevalent in patients undergoing valve replacement than other operations like CABG. The most postoperative pulmonary complications occurred in patients with obstructive lung disease. And interestingly, the in-hospital deaths in this study, which again were rare, were not directly related to pulmonary complications. But again, you could bridge some of these patients to surgery with VV ECMO. And again, the data here is extremely limited. This is actually a report from Australia that detailed their use of preoperative ECMO as a bridge to cardiac surgery, 16 patients only. And I just highlight the fact that only one patient of the 16 started on VV ECMO was actually converted to VA ECMO to bridge to cardiac surgery. So again, while theoretically possible, not something that's typically used in routine practice. So again, I wanted to conclude by providing a summary that while pulmonary complications are common in postoperative settings and very common in cardiac surgical patients who seem to be at higher risk for a multitude of reasons, frank respiratory failure requiring VV ECMO following cardiac surgery is pretty uncommon. But that being said, amongst those patients where in these four categories, such as having very severe postoperative ARDS, bridging to lung transplantation or supporting patients following lung transplantation with primary graft dysfunction, which again would be very much like lung injury from ischemia reperfusion that can be managed like postoperative ARDS with VV ECMO. There's at least theoretical use of VV ECMO for minimally invasive cardiac surgery, and again, a potential to bridge patients with pre-existing lung disease to certain types of cardiac surgery. And with that, I will finish. I'm happy to take any questions that the group might have, and thank you for your attention.
Thank you very much, Dr. Eddie Fan. Very beautiful, comprehensive lecture about VV ECMO. Please write your questions in the Q&A section if you have any questions. So I will start. I will give you a question, Eddie. So if there is, moderate RV dysfunction post cardiac surgery with ARDS, how would you tackle that? Would you just say, okay, I'm gonna go VA for full support and then maybe switch to VV? Would you just do VV and support the RV with pharmacotherapy, or would you ever use the RA-PA configuration, the PROTECDO cannula?
Yeah, so I think it's a good question, and I'm sure like in different centers there would be different approaches. So presuming that you've come out of the operation, the chest is closed, and the patient hasn't for some other reason gone on to VA ECMO, if there's isolated RV dysfunction and, as you said, ARDS or severe hypoxemic respiratory failure, my view would be to go on to VV ECMO first. It's a simpler configuration to manage. I think if there's no other compelling reason to go on to VA, like there isn't also concomitant left ventricular dysfunction or other reasons, then going on to VV would be our primary mode of support. And again, there's likely, if part of the RV dysfunction is at least being mediated by the challenge of the respiratory failure, so both the underlying lung injury leading to problems with the RV and perhaps the degree of mechanical ventilation support or intensity required to help the patient through these challenges, then VV ECMO can both lead to benefits for gas exchange, but also benefits for the RV by reducing the intensity of mechanical ventilation that needs to be provided. as well as correcting hypercapnia, correcting hypoxemia can lead to also benefits for the RV. In fact, we have nice physiologic data on how RV function improves with the institution of VV ECMO from Alain's group in Paris, published in the Blue Journal. So I think from our point of view, we would start with VV ECMO, and certainly if we were running into ongoing issues with hemodynamic compromise or shock related to RV dysfunction that isn't corrected by the VV ECMO, we would convert that patient to a different kind of support.
Thank you very much, Eddie. That's a very good answer. There's a question about since Toronto is doing a lot of I don't know how many, but pulmonary endarterectomy. So what is your experience with that, and when do you use VV ECMO in this kind of surgery?
Yeah, so again, I think we're very fortunate to have gifted surgeons who do our pulmonary endarterectomies. It is true we're doing I think two to three pulmonary endarterectomies a week now. So we do quite a few here. The vast majority again improve very much with careful sedation, management of their pulmonary pressures, and diuresis following their operation, and don't run into problems with very severe respiratory failure. I would say probably less than 1 to 2% ever get onto ECMO, and the criteria that we would use would be very similar to Eolia criteria. So again, I would say the vast majority of these patients run into challenges with either ischemia, reperfusion, injury that leads to very much like ARDS and severe hypoxemia. And those patients, when they meet criteria very similar to Eolia, we would put them onto VV ECMO to support them. And again, those runs typically are relatively short. Once we resolve the period of ischemia reperfusion. I would say it's rarer for patients to come out of the operating room after successful endarterectomy to have ongoing issues with either bad right ventricular dysfunction or biventricular dysfunction, if that happens to be the case. And so it'd be exceedingly rarer for these patients to require, in at least our experience, VA ECMO support for their RV following a successful endarterectomy type operation. I would say in those cases that where there's severe RV dysfunction that doesn't improve, those patients declare themselves intraoperatively, and they typically have problems coming off bypass, and they come out of the operating room already on VA ECMO.
Thank you very much, Eddie. Here's a simple one for you. How would you define ARDS post cardiotomy? Is it the same definition? Would you use the Berlin criteria or something else?
Yeah, I think it's a good question, simple answer. Yeah. Post cardiotomy ARDS is same rules or definitions I would say apply. Yeah.
Thank you very much, Eddie. There are two questions back to Prof. Allen here. One is about anticoagulation. Would you ever start with anything other than heparin, and is there any evidence behind that? Would you do bivalirudin sometimes or other agents?
No.
Go ahead, Alan. Yeah.
Well, in our experience, we still stick with the old and fraction heparin because once again, it's easy to stop, easy to reverse. And well, this is the drug that's been used for surgery. And the second message is that you need to be very careful in the hours following surgery. In some cases, you will be dealing with two types of major issues. Valve thrombosis, for example, if the patient has a mitral mechanical heart valve, which is a formal indication for anticoagulation, full anticoagulation, and a patient who is bleeding or a patient who is on ECMO, well, you need to adjust. One small message: if the patient is bleeding, just stop heparin, stop every anticoagulant until you have fixed the issue. We also have been using all types of major antithrombotic or anticoagulant system in these patients, including activated protein C. Not the protein C, but the major potent anticoagulant in these patients. But the key message is stop anticoagulation if the patient is bleeding.
I completely agree with the message that don't start heparin too early if your patient is bleeding. I've seen it a lot with trainees, and I've seen it a lot of people itching to start heparin, if your patient is bleeding, treat bleeding, relax, and then you will anticoagulate once the bleeding stops, and not immediately. I give them a window as well for a clot to form and all that. A question, Prof. Allen, about LV unloading. Someone is asking about your center experience with LV unloading. Would you do it for everybody, or would you do it for selective cases?
For now, we're randomizing patients because we have this study ongoing. And there is a major debate in the community when looking at registries, including the LSO registry, including patients post-op. There is a strong trend towards benefit in terms of mortality. The latest is probably the latest series are not that in favor. And there may have been selection biases, as always, in retrospective registry. So this is the reason why we have, and now these studies are going. There was one with Impel in Germany and our Elodia trial in France. And we'll see. My gut feeling is that, less than 1/3 of the patient actually need unloading. And we are moving back to the old Swan-Ganz pack catheter also to monitor the LV and the wedge pressure, and it's also now on the list of the criteria we use for indicating unloading in these patients.
Thank you very much. So sounds like we don't have enough evidence, and it's not for everybody until we have enough evidence.
For sure. Just one quick word. In our experience, those who might benefit the most, large left ventricle dilated, very little remaining LV ejection, severe mitral regurgitations. Those are the factors which are clearly associated with the need for some form of venting.
Yeah, no, thank you very much. Very, very comprehensive answer. The old teaching, I remember the old teaching is either they have to eject or to have a vent. So you can go by that until we have better evidence.
Sure.
Back to you, Eddie. There's a question about your threshold after lung transplantation to go on VV ECMO. What is your threshold? Would you do it for more people? Would you be very
Yeah, I actually, again, fortunately for us, I would say it's still a pretty rare event to get such severe PGD that our patients would get onto VV ECMO post lung transplantation. But we still are pretty conservative. We would use, again, I would say Eolia type criteria, so very severe hypoxemia or challenges with injurious levels of mechanical ventilation as a trigger to go on to VV ECMO. So again, very much like Eolia criteria, even in the post lung transplant patient. And again, it's sometimes not surprising, much like the risks that Alain talked about for the post cardiotomy patient, like which one of these patients will typically run into trouble with bad primary graft dysfunction. So very sensitized donors that were very sick going in, patients that were already bridged for a very long time to lung transplantation preoperatively. These are some of the patients that we typically see will run into trouble with severe primary graft dysfunction and may require ECMO, but fortunately it's a pretty rare situation. Maybe the only one teaching point and caveat for patients who are managing these patients in lung transplant centers is that, again, at least in our center, while we're conducting randomized trials, we typically, once the patient does get onto VV ECMO, we dial down the intensity of mechanical ventilation quite significantly, so they may not be generating very much tidal volume at all. In the lung transplant patient, you want to be very cautious about that, right? Because now they no longer have a dual circulation to their lung. They no longer have the bronchial circulation. So if you reduce mechanical ventilation drastically in the lung transplant patient who's supported with VV ECMO, and there's widespread atelectasis, that lung is very at high risk for ischemia and necrosis. So even in the lung transplant patient who's being post-lung transplant patient who's being supported with VV ECMO, you want to provide some sort of maybe ultra protective mechanical ventilation, ensuring some tidal volume goes in to prevent widespread atelectasis in that lung to prevent graft ischemia and necrosis.
Thank you very much. Here is a final question here, which is, I think the answer is complex, not easy. He's saying, if you have a pre-existing EF in 20 to 25% and ARDS, how would you decide if you have to go VV or VA after cardiac surgery?
Yeah, I think, again, it kind of depends on what the main problem is. I think if the patient has a pre-existing poor EF, like left ventricular ejection fraction, but the main issue is ARDS and or RV dysfunction, then I think I would still try VV ECMO first. I think if it's quite clear that the main challenge is maybe not necessarily gas exchange, but hemodynamic instability or shock because of biventricular failure, then maybe the configuration to go on first would be VA ECMO. But again, it kind of depends a little bit on what the primary issue is, like what is the primary problem and what are the bystander problems versus, so if it's mainly the lungs and some RV dysfunction and maybe LV dysfunction, then I would still go for VV ECMO first. But if the main issue is biventricular dysfunction, hemodynamic instability, and cardiac dysfunction, then I would go for VA, and the lungs are somewhat affected, then I would go for cardiac or VA ECMO in that situation. I don't know if Alan feels differently.
Completely agree, Eddie, with you.
Thank you very much. Yeah, that's very good. And please remember that switching from VV to VA or VA to VV is not that difficult, right? It is simple and can be done at the bedside. And it's just adding a cannula using the same circuit. Okay, well, we're running, I think, out of time. So thank you very much for our speakers, Prof. Alan Combe for speaking about VA ECMO post-cardiotomy, and for Prof. Eddie Fan for speaking about VV ECMO post-cardiotomy. Thank you very much for Ashwag and for her team for coordinating this great day and great talk. Ashwag, I'll give you the microphone if you want to give a final word.
Thank you so much for the excellent, informative both lecture. And thank you, and we're appreciating your time. Thank you, Dr. Aus.
Thank you.
Thank you.